Ladies and gentlemen, we have one presentation left. This is Jeff Scher talking about the Primary Spine Practitioner Program.
Well, I'm Jeff Scher, and today I have the privilege of sharing with you an introduction to the Primary Spine Practitioner, or PSP. And I wish to thank those who have made this possible, Bill Kuzar, Mike Barber, and of course, Lawrence Dawson. Thank you very much for inviting me to come and speak. I'm a recent alumni of the first cohort of the Certified Primary Spine Practitioners Program at the University of Pittsburgh. Trained there, the rated #1 in the U.S. for physical therapy training. Now, Bill's going to be handing out some questionnaires about interest in the PSP, and there is an interest in bringing this over here. The program was developed and instructed by chiropractors. Here's Don Murphy, by physiotherapists, this is Mike Timko, researchers, chiropractor Mike Schneider, psychologist Carol Greco, as well as public health specialist, radiologist, pharmacologist, physical medicine rehabilitation specialist, and surgeons. I first heard about the PSP 5 years ago when I took my son Jonathan, a new chiropractic student at WEOC, to a BCA conference at the AECC. And there Donald Murphy gave a lecture on his new book, The CRISP Protocols, Clinical Reasoning in Spine Pain. He was part of Spine Care Partners developing the PSP movement worldwide, and Spine Care Partners were training chiropractors and physical therapists to work as PSPs in hospitals and clinics in the US. I said to my son, you know, I think this is the future, John. The PSP offers a value-based route for the integration of chiropractic into the wider healthcare arena. And Dr. Murphy mentioned the interest that Pittsburgh University had in putting this program on as a validated program, and that the course might be offered soon. Well, of course, I was very interested. And then John and I attended a second lecture on the PSP 3 years later, this year by Spine Care partner John Ventura at a BCA conference at WEOC. And the following week, the University of Pittsburgh announced the course. I think it was George Carruthers who put it online, and I applied and was thrilled to be accepted. Pittsburgh is a beautiful city. It's an interesting city, and this is the view of my hotel room. Out my hotel room, you can see the Citadel of Learning on the horizon there. It was once the steel capital of America. This is Hot Metal Bridge. I walked over this bridge to the university course every morning on the weekend courses, and I managed to go 5 times over 15 months, so I saw it in every season. The views of Pittsburgh were stunning from this bridge. Pittsburgh is now a university city, rather, and a city of commerce. The old part of the city is still very beautiful, with museums such as Carnegie Mellon Natural History Museum, with its diorama, very impressive diorama, the Carnegie Mellon Museum of Art, where you can see this wonderful Monet, and of course the Andy Warhol Museum, where you can sit up like Andy himself. Now, Pittsburgh has a vibrant sporting history and a lively nightlife, so it's a wonderful place. The first cohort was composed of an equal mix of 60 chiropractors and 60 physiotherapists. 60 chiropractors and physiotherapists, 30 each. The course consisted of 120 hours of online study and 5 live weekend workshops of 12 hours training over 15 months. Quizzes were completed on each online module to progress through to the course, and examinations on each unit and corresponding workshop required a total of 75% to matriculate to the next unit. The final examinations consisted of a radiological imaging examination, a live patient encounter with a trained Pittsburgh actor, it's very interesting, and a viva voce with 2 instructors on any aspect of the 15 months of training. And the course was rigorous. But on every workshop Saturday evening, a social was organized at the Fuel and Fuddle Pub, with food generously provided by the university, and we all got to know each other and became firm friends. I found this course challenging, but also very exciting and thoroughly stimulating. My enthusiasm for practice has been enhanced, and I'm pleased to report that I passed with a 92% average and became the first certified PSP in the UK and Europe in December of 2018. The course has now been refined, and it consists of 4 units 4 units with 4 workshops over 12 months, which I think is ideal. So I'm here today because I'm endeavoring to further the worldwide PSP movement into the UK and Europe, and hope that you, after my introduction today, may be interested in joining me, and you can indicate that through your questionnaires that Bill's just handed out to you. So the slide presentation I'm about to show you as an introduction to the program is part of the PSP Certification Unit 1. Dr. Donald Murphy presents the role of the primary spine practitioner in healthcare, and I have permission from Dr. Murphy, Spine Care Partners, and the University of Pittsburgh to share this with you today. Dr. Murphy is a chiropractor by training, a primary spine practitioner by practice. He is a medical director of the spine care program for healthcare system called Healthcare New England in Rhode Island. And Don is also clinical assistant professor at the Department of Family Medicine at Alpert Medical School at Brown University. Today we're going to be talking about the role of the primary spine practitioner in healthcare. We are specifically going to talk about the present status of spine care and the need for a new approach to primary management of spine-related disorders. We are going to present, define, and codify this new practitioner type, the primary spine practitioner. And we will be getting into some of the specifics of the skill set that is necessary for a practitioner to be able to function as a PSP. PSP, of course, is the abbreviation for primary spine practitioner. The problem in spine care today, encapsulated into a nutshell, is rapidly rising cost, rapidly rising disability. This, of course, is unsustainable. There is much effort in today's healthcare generally to move to more value-based systems, trying to improve the value of healthcare services. And what is value in regard to healthcare? Well, value is equal to outcomes over cost. In spine care today, we currently have rapidly increasing cost, rapidly rising disability, and this necessitates a change in how we administer spine care in our system. One of the primary problems for this poor value and poor environment is what's called the spine care supermarket. This term was originally derived from a paper written by Scott Haldeman and Simon Digenaeus in Spine 2008. In the spine care supermarket, Haldeman and Digenaeus analogized the situation of the spine pain patient as a person who is walking through a foreign supermarket. They're walking down the aisles, and there are all these products and services on the shelves, and they don't know what is right for them. They don't understand what the labels say because it's in a different language. In the spine care supermarket, we have all these different products and programs and methods and techniques and devices and procedures and all the stuff that is available to the spine pain patient. And we have a variety of practitioners, both medical and non-medical, offering services to the spine pain patient, often without any evidence of benefit, but also without any kind of coordination of these activities. This is the spine care supermarket the spine care patient is faced with today. It's a very messy situation, a very inefficient situation, and as we have seen, a very costly and ineffective situation. This situation in healthcare calls for a drive in reform. Healthcare in general, not just spine care, but healthcare in general, is trying to come up with ways in which we can increase the efficiency, increase the effectiveness, and decrease the cost of healthcare. A big focus of this healthcare reform is greater emphasis on primary care, shifting medical care away from a specialist focus and more towards a primary care focus. There is good evidence that this is good for healthcare. However, in the area of spine-related disorders, this is problematic when it comes to traditional primary care practitioners. Here we're talking about family medicine doctors, general intern medicine doctors, nurse practitioners, and physician's assistants. Number one, these practitioners, primary care doctors in particular, are already overburdened. They're taking a lot of responsibility for the health of patients, and to add to their burden, spine-related disorders is problematic in and of itself. But this is made more problematic by the fact that, by and large, traditional primary care practitioners are not well trained in spine. They don't get a lot of time and training and experience with patients with spine-related disorders. Consumer Reports recently conducted a large survey of their readership, and they asked them their satisfaction with medical care with different types of practitioners. Primary care doctors actually ranked last in terms of patient satisfaction with their back pain care. Now, this is not a knock on primary care physicians. The fact is, most of the studies and surveys you see in other areas of medicine, primary care doctors rank very high in terms of satisfaction, in terms of respect, in virtually all other areas of medicine. It is only in spine care that primary care physicians ranked last. So, if we are going to shift the focus of spine care to primary care, we need to take a different approach than traditional primary care for spine-related disorders. So what we are trying to do is to move from this supermarket environment to an efficient system. And that is where the concept of primary care services and primary spine practitioner come into play. There have been proposals, and this was a study by Catherine Dower and her team, where they discussed more efficient, effective, and innovative ways to provide primary care in general. And so in the area of spine care, do we build a new profession from the ground up, a new profession of primary spine practitioners that we build schools for and design programs for? This is a very inefficient way of going about it. Starting brand new educational programs from the ground up is very costly and very time-consuming. And the fact is, we don't have time. We're in a situation where we have a desperate need to improve efficiency and effectiveness now. We don't have time to train new professionals from the ground up. So what Dower and her team suggested is taking existing professionals with existing skill sets and augmenting their skill set to serve in new, innovative ways. And part of this will require additional education, additional training, and in some cases, expansion of scopes of practice. Even the Center for Medicare and Medicaid Services, CMS, is calling for a refitting of the existing workforce to play a new innovative role in the new healthcare system for the purpose of improving efficiency, effectiveness, and cost effectiveness. So this is how the primary spine practitioner concept actually evolved. Dr. Scott Haldeman is really the pioneer. He is the godfather of the primary spine practitioner movement, and a lot of the genesis of this concept was started by him. Now, Don Murphy wrote one of the early papers. He was the lead author of this paper, introducing the concept of the primary spine practitioner and outlining its benefits to the healthcare system. You will see here that Michael Schneider, chiropractor, researcher, and instructor at University of Pittsburgh, was also a co-author on this paper. And this paper is available open access and is required reading in the PSP course at University of Pittsburgh. So basically, primary spine practitioner training is refitting chiropractors and physical therapists, and possibly others who may have the basic skills that are needed, to play new and innovative roles in the healthcare system, such as the primary spine practitioner. So, what is the job of a primary spine practitioner? What are the roles that he or she will play? In a nutshell, it is primary care for patients with spine-related disorders, and that is neck pain, back pain, and other symptoms that may relate to the spine in one way or another. This involves the diagnosis and management of the majority without the need for referral. This is at the heart of efficiency of the model and is at the heart of primary care in general. The diagnosis and management of majority without the need for referral. But importantly, this also means identifying those people who need the services of other members of the spine care team and serving as the captain of the spine care team, serving as the coordinator, as the person connecting the dots in the spine care program to take that spine care supermarket and turn it into an efficient process by which patients can receive the care they need when they need it. And that means being able to identify those patients who need further diagnostic workup through history and examination. It also means triaging them towards the imaging test or specialist consults that they need. It also means following up with them after they've received these diagnostic consults or services and then determine what is the next step. The minority of people with spine-related disorders do require or benefit from invasive procedures such as injections and surgery. And this will be the role of the primary spine practitioner to determine what patients need these invasive procedures and to be able to counsel the patient accordingly and to triage them to receive these services and follow up with them afterwards to keep them on the track to recovery. So basically, what this involves is guiding the patient across the full cycle of spine-related disorder. And when it comes to spine-related disorders, the full cycle means the patient having a pain, disability, and suffering experience. Patients don't come to us with pain. They come to us because they are having a pain, disability, and suffering experience. It is the PCP's job to guide them along from the pain, disability, and suffering experience to resolution. That means managing the majority without the need for referral, not needing any other professionals to guide the patient along the process to recovery, but also identifying when they do need other professionals who may play a role in one way or another at one point or another in this process of the patient moving from pain, disability, and suffering experience to resolution. You may have heard of these terms in healthcare or reform before, moving from silos to teams. To use the terminology of Boston surgeon Atul Gawande, who has written much about improving the efficiency of healthcare, moving from practitioner functioning as a lone cowboy to groups of practitioners working like a pit crew, working together as a team, each person having their own specific job and doing that job well. And that means if you're going to have a pit crew, you need to have a pit crew chief. And in spine care, the crew chief is the PSP. Again, primary spine practitioner has the knowledge, training, and skills to manage the majority of spine care patients without the need for referral. The PSP can identify when the patient does not need professional services, but can self-manage their condition, perhaps not completely, but to a great extent. But the PSP also interacts with other professionals in the healthcare community who are available to him or her to make sure that the patient gets the right care at the right time. And so, utilizing other members of the team, other members of the community when necessary, knowing who the patient is to see and when, or knowing when the patient doesn't need to see any of the other members of the team, in both scenarios, rapidly and expeditiously moving them along the full cycle from pain, disability, and suffering experience to resolution as quickly as possible. So what kinds of skills will this primary spine practitioner need? Well, first and foremost, the PSP needs to have a wide-ranging understanding of the biopsychosocial nature of spine-related disorders. They need the knowledge, training, and skill to address the biological factors, the psychological factors, and the social factors that contribute to spine-related pain, suffering, and disability experience. Most spine-related disorders result from a combination of these factors, and it is essential that the primary spine practitioner understand these contributing factors, identify them, and then understand the patient in order to best manage them. So this means skills in differential diagnosis. In some environments, this is called medical screening, and any patient with symptoms related to the spine are eligible to see the PSP, and some of these patients will suffer disorders related to cancer, infection, or other ominous factors, but also things that are, for lack of a better term, mechanical in nature. The PSP has to be able to differentiate ominous factors specifically contributing to the patient's pain, disability, and suffering experience, and who require further diagnostic workup. And this also means understanding the indications for and the ability to interpret spine imaging. When it comes to spine, the imaging modalities that are most relevant are radiographs, MRI, and CT. The PSP recognizes when to order these tests, but also how to read these tests. When patients attend with their imaging, or when you've ordered imaging, the patient expects you to read the study, not just to report, and to be able to explain to them in detail what are the relevant findings, if any. The PSP must possess skills in evidence-based treatment methods. These include manipulation and manual therapy, end-range loading, or the McKinsey approach, neural mobilization, and stability exercise or other exercise approaches. But the PSP must also possess wider-ranging skills than just treatment methods. Skills in education, motivation, and guidance is at the heart of effective spine care, helping patients to help themselves and to self-treat their problem whenever possible. The ability to incorporate effective psychological methods is also essential. The two psychological schools of thought that have been shown to be effective in patients with spine-related disorders are cognitive behavioral therapy and acceptance commitment therapy. This doesn't mean the PSP has to acquire a PhD in psychology, but it does mean that they need to understand the methods of these different psychological schools of thought and to be able to contextualize these messages in the care of patients with spine-related disorders. And of course, the ability to manage disability, the ability to help the patient navigate the stay-at-home and/or return-to-work process. Return to work is part of therapy. Getting people back to work or keeping them at work is an essential part of overcoming and resolving the pain, disability, and suffering experience of work-related, spine-related disorders as quickly as possible. And that means motivating people. Motivating people to return to activities, to engage in exercise, and to self-treat themselves with approaches that are effective for them. Motivational interviewing has been an effective way to do this. Also, to avoid iatrogenic disability. This doesn't mean doctors harming patients physically. It means promoting disability through how concepts and conditions are indicated to the patient. How we communicate with the patient goes a long way towards either helping them overcome the problem as quickly as possible or prolonging their disability. And patient education is one of the most important roles of the PSP. Skills in case management, that is using sound evidence-based clinical reasoning to make diagnostic decisions, to make treatment decisions, and to make referral decisions, and to coordinate the care of patients that are seeing other practitioners whose skills they need, expeditiously moving them from the pain, disability, and suffering experience to resolution. That means in many cases coordinating the activity of a variety of practitioners depending on whom the patient is seeing at any given time. Excellent communication skills are essential. The PSP, as a primary level practitioner and often a first contact practitioner, will need to communicate with patients, with other practitioners, with staff, with other members of the healthcare team, perhaps with administrators of hospitals and clinics, case managers of work-related injury or medical legal situations, and the community at large. All this is part of primary spine care. The establishment of a clear diagnosis with every patient suffering spine-related disorders may be challenging. However, developing a diagnosis, at least a working diagnosis, and communicating that clearly to the patient has been shown by several studies to be the most important factor in patient satisfaction. So again, the primary spine practitioner has the knowledge, training, and skills to manage the majority of spine care patients without the need for referral. In essence, if you are functioning as a PSP, you are the primary care practitioner for a specific set of problems, spine-related disorders. Maybe the best analogy is the dentist, who serves as a primary care practitioner for oral health. The PSP serves as a primary care practitioner for spine health. So primary spine care services under the direction of a PSP are not simply a theoretical model. They are currently being applied in various environments. 3 hospital systems currently have established these services. There's Beth Israel Deaconess Hospital in Plymouth, Massachusetts. There's Mercy Center Hospital in Chicago, and Care New England Health System, Brown University Medical School in Rhode Island. These services are also being implemented in a large community-wide program in upstate New York associated with Blue Cross Blue Shield. PSP services are not a theoretical concept. It is a tangible concept that has been applied effectively and efficiently in different healthcare environments. So today we have reviewed the present status of spine care and the need for a new approach to primary management of spine-related disorders. We introduced this new practitioner type, the primary spine practitioner, and we defined the skill set necessary to function as a PSP. I'm endeavoring to further the worldwide movement of the PSP into the UK and Europe, and hope that you, after today's introduction, will may be interested in joining me in doing that. Here are some further resources that you might be interested in for the PSP, and also some information if you'd like to keep in contact with me about the PSP. The PSP University of Pittsburgh is the website there. Clinical Reasoning of Spine Pain is a website set up by Donald Murphy, and he's got some resources. And Spine Care Partners has a link there. And then the Primary Spine Provider Network is an online program where you can get 12 units in lumbar spine care, 12 units in cervical spine care, and a master series. And they're now interviewing some of the PSPs that have graduated and seeing how they're doing in work. So that's an ongoing thing you can watch it's about 2 or 3 Thursdays each month. So how many of you might be interested in a 12-month online program in the UK with 4 live weekend workshops located in the UK? That's great. That's fantastic. We've got a group. We've got a nucleus. Well, please fill out these questionnaires, and please give them to me or to Bill, who handed them out, and we'll keep in touch with you. And thank you, Lawrence. That's great.
Great.